Okay, hi everyone. I am Arlyn, and as Jake said, my presentation will be on the generation of synthetic CT images from MRI of brain cancer patients using deep neural learning. Now, first and foremost, I'd like to introduce my supervisors, Dr. Jake Kendrick and Dr. Pejman Rowshanfarzad, whose undying patience and indispensable knowledge has helped me throughout the past semester very much. I would also like to mention Dr. Rowan White and Mr. Branimir Rusanov in the Department of Radiation Oncology at Sir Charles Gardiner Hospital, whom I look forward to be working with greatly in the future. So first starting off, looking at brain cancer and its treatments. Brain cancer actually can be characterized as a relatively rare type of cancer that has significant mortality outcomes. In Australia alone, the estimated incidence rate of brain cancer is 7.3 cases per 100,000 persons. However, despite being ranked 17th in incidence rate amongst diagnosed cancers, brain cancer is actually the 9th most common cause of cancer-related deaths in 2023. Now, the most common type of brain cancer, a high-grade form of gliomas called glioblastomas, has just a 5.75-year survival rate. And these high mortality rates, despite lower incidence rates, really highlights the urgency in improving upon the current treatment procedures that we have. And this is particularly pertinent for brain metastases, as you can see down here, which are approximately 10 times more common than primary brain tumors. In fact, brain metastases account for up to 20% of metastases from the three major forms of cancer, those being of the lung, the breast, and melanoma, which in turn constitutes 67 to 80% of all cancers. Now, just as an example of the morbidity we're dealing with here, the graded prognostic assessment for brain mets from melanoma estimates a survival range of just 5 to 34 months, depending on the level of progression of the tumor. For this reason, the research we will be doing will mainly focus on brain metastases first, before possibly expanding to encompass primary tumors and other anatomical sites as well. Now, shifting to the current standard procedure for the treatment of brain metastases, this involves surgical resection to remove maximal tumor volume, followed by adjuvant therapies. However, because of the blood-brain barrier, treatments such as chemotherapy that rely on pharmaceuticals are not often used. Instead, concurrent radiotherapy treatments such as whole brain radiation therapy or stereotactic radiosurgery are far more effective. The application of AI, especially in the context of this project, is therefore mainly to improve the radiotherapy proportion of this existing treatment regime. Now, at Sir Charles Gardiner Hospital, the current radiotherapy workflow looks something like this. The treatment begins with referral, consultation, and evaluation of each individual patient case. For those who have been prescribed radiotherapy, we first obtain an MRI of the brain region. This gives us superior soft tissue contrast that is necessary for accurately delineating remaining tumor metastases, especially for the often numerous and small brain mets. However, MRIs don't provide us with the electron density information that is required for the calculation of dose and treatment planning. So next, a CT session is needed to obtain planning CTs that is used to create the dose distribution plans, which then need to be approved before we can finally move on to treatment. As you can imagine, this entire planning process can be quite time-consuming. In general, it takes around 18 days. But there have been instances where it takes up to 28 days for the entire process. And in this extended period, the tumor physiology can change quite drastically depending on the type of tumor and how aggressive it is. Now, a major bottleneck in this planning process lies here in the CT planning process, specifically in gaining access to the planning CTs, which can take up to 1 to 2 weeks. This is almost half of the entire planning process. So to improve upon this process, we can use AIs to assist in creating a new RT workflow that only relies on MRI in the treatment planning process. This process will not only significantly expedite the treatment process, but also reduce the overall exposure of ionizing radiation, namely from the planning CTs, potentially improving survival outcomes. by eliminating the need for planning CTs, there is also the added benefit of reducing the cost to patients and the public healthcare as well as freeing up access to the already limited number of CTs for other patients that may need it. So this brings me to the motivation of this entire project. This MRI-only workflow can be made possible through the generation of synthetic CT from MRIs of brain metastases. The aim of this research is to ultimately create a robust neural network that can take only MRIs, seen here in the left of the image, and turn them into accurate synthetic CTs containing the electron density information. Now, in order to achieve this, I will follow 4 main objectives. Firstly, I will search the local repository for a large number of high-quality ground truth intracranial MRIs and their corresponding planning CTs, and subsequently do some pre-processing on this data. The next objective is the model training phase, in which I will experiment with various deep learning architectures, as well as their hyperparameters, such as their loss function, their activation functions, and other data augmentation techniques, to hopefully generate the best final model possible. Then I will evaluate the model using clinically relevant metrics to determine the overall quality of the synthetic images and compare the virtual dosimetry plan made from these synthetic images with the reference plans created from real CTs. And finally, I will attempt to quantify the potential improvement that the deep learning model is able to provide with the current workflow at Sir Charles Gairdner Hospital. Now, looking at the methodology in more detail, I'm hoping to gather more than 100 paired intracranial MRIs and planning CTs of patients that have presented with brain metastases. Then I will perform some data pre-processing on the MRI, such as bias field correction to account for any non-uniformity in the magnetic field, and histogram matching to address variations in the MR intensities across the image. And although there is a relatively large data set of 100 paired images, I will also use data augmentation techniques to further increase the effective size of the data set. Then, Velocity software will be used to spatially register the MRI and CT images, with the MRI being designated as the moving image and the planning CT as the fixed image. Rigid intrapatient registration will be done to linearly align the MRI and CT scans, while deformable registration will be done to account for any non-linear intramodality differences, such as the difference in intrinsic resolution between MRI and CT, as well as any soft tissue deformation that occurs between the time that is taken for the MRI scan and the CT scan. Now, it must be noted that for some architectures, we will use only rigid registration, whereas other architectures will use both. This selection will be made based on the architecture and the loss functions that are employed. And this is something I will discuss a little bit in more detail later on. Now, the architectures I will be focusing on will mainly be the conditional and cycle generative adversarial networks, and also generator-only networks like the famous UNet model. These will be assembled using the Keras packages with unique combination of hyperparameters, such as the mutual information and perception loss functions for the generator components, as well as, for example, the binary cross entropy and the mean squared error functions for the CGAN and CycleGAN architectures, which utilize discriminators. To compare the synthetic CTs with the real planning CTs, we will use the dissimilarity coefficient to assess geometric fidelity on the contours, and the mean absolute error, peak signal to noise ratio, and the mean structural similarity index measures will be used for intensity related comparisons. To the right here, we can see a summary of the model training process that I've just described here, beginning at the top with the training data, including intrapatient registration, then training the network. This example here is a GAN network, and then finally testing the data set at the bottom. Now, so once the final model has been chosen, it will be evaluated using a test set containing 30 unique MRIs taken from that same repository. The synthetic CT scans will be tested using the same metrics as I described before, DSE, MAE, followed by a comparison of a virtual plan created from said synthetic CT scans with the real dose distribution plans. The clinical metrics that I will use will be the dose volume histograms for planned tumor volumes, and that's for specific organs at risk, such as the optic nerves and the brain stem. And also I'll use 3D gamma analysis as well. These dosimetric criteria were actually selected according to the departmental protocols at Sir Charles Gardner Hospital. And on the right here, you can see visually how each of these metrics quantify the accuracy of the final model. I want to especially note that the bottom right of the first image shows the difference in the DVH between the real and synthetic CTs there. So you can see that there is a minor difference, but there is a difference. So finally, the potential improvement on the current workflow will be estimated by performing a review of the 1-month planning system at Sir Charles Gardner Hospital. This will involve removing the intracranial planning scans from the existing schedule to determine the increase in planning appointments that we get. And this is done based on the assumption that the other patients on the departmental wait list will take the places of these missing intracranial planning scans. Then the increase in volume of patients will be proportionally applied to the median wait time to hopefully quantify this potential improvement. Now, research into generating synthetic CT images from MRIs has been applied to many different anatomies, including the brain, head and neck, breast, abdomen, and pelvis, just to name a few. There's actually a budding research, a subject of research with publications arising since as early as 2015. And in these publications, neural networks have successfully produced less than 2% absolute dose difference between the maximum dose of the virtual plan and the real treatment plan. So these are some good numbers here. Of particular interest, though, are these 4 publications here. Firstly, in 2020, using 402 paired images of the brain, Andrews sought to optimize many of the parameters related to using the deep learning models. Particularly, this publication gives great insight into the impact of training set sizes and the various MRI sequences on the quality of the synthetic CT that is produced, as well as examining the different endpoints when using, say, a conventional neural network that focuses on maintaining high image resolutions, such as the high-resnet, and comparing it to other models, such as the 3D UNet model. Now, the work by Volterink in 2017 demonstrated the possibility of actually using unpaired and unaligned data by training a cycle GAN model that was able to outperform paired GAN models in many metrics. However, there is still room for improvement in this study, as the study only used 24 2D, not 3D CT MRI images, and actually didn't perform evaluation of the impact on treatment planning, which is something that I intend to do myself. And perhaps most importantly, the recent publications by Kazemafar aim to mitigate misalignment during image registration by creating a custom mutual information loss function for their conditional GAN model. Now, this mutual information loss function was constructed to implicitly minimize misalignment between MRI and CT, and was able to produce less than 0.5% or 0.3 gray difference in the clinical target volume dose from only 77 paired 2D images. Zoe then took this further by combining the mutual information loss function suggested by Kazemafar with other loss functions, and then applying their own iterative refinement and knowledge distillation process in an effort to further improve registration misalignment. As a result, they were able to attain a less than 1% dose difference for 48 head and neck patients. So the techniques that are used in these particular publications really helped inform how I will tackle some of the common problems that seem to plague training and testing deep learning models. Firstly, the sheer computational power required to train these models means that in some cases it's taken up to days of continuous training to create a working model. This time constraint essentially limited the amount of practical information and experimentation to 1 or 2 architectures only for most of these publications. However, with multiple dedicated 4090 graphics cards, we are hoping that this will allow us more freedom to experiment with different models without compromising on the accuracy or resolution of the final synthetic CT. Additionally, there is a general problem surrounding obtaining good amount of ground truth data, which is especially true for studies by Volterink and Zoe. This problem was solved, quote unquote, solved by data augmentation alone. However, we are hoping that the 100 plus paired images used in training and the 30 testing images will allow us to create a more robust model than we have seen in previous studies. Now, as I've mentioned before, there's been misalignment issues when registering the MRI to CT that in turn have reduced the accuracy of the resultant synthetic CTs. To combat this, I intend to experiment with the mutual information loss functions, which is proposed by Kazemafar. This mutual information loss functions means that only rigid information registration is required, and the deformation registration is implicitly located in the actual mutual function. So that will hopefully reduce the overall misalignment produced there. And furthermore, I will also take components from the process introduced by Zoe to further enhance this misalignment mitigation. Finally, one main issue that I've yet to mention is multi-center issues that affects all the publications that I've come across so far. There have been limited studies that have examined the impact of synthetic CT generation from MRIs obtained in different devices that differ from the ones that are used in training. This actually seems to be an often overlooked factor that may limit the generalizability of the final model, which in turn, I believe, has limited clinical application. By focusing on acquiring data from different MRI machines and with different MRI sequences, I'm hoping that this will allow the model to be more seamlessly integrated into not only the system at Sir Charles Gardner Hospital, but also at other institutions too. Now, finally, here is just a project plan of what I have. I intend to spend a lot of the time in this middle section here, a couple of months, in training and experimenting and designing and constructing different combinations of hyperparameters and models. And once I've evaluated a good model, I will then go on to create and compare treatment plans, assess the potential workflow, and then analyze before writing the thesis. And that's about it. Thank you very much for listening. Got any questions?
Brilliant. Thank you very much, Arlyn. We'll open the floor to questions now. So Suki, did you want to jump in first?
Yes, Arlyn, you have a very good presentation. Think of all the sites you can use an MRI to plan. The brain would be the most reliable. I find that if there is an organ that's moving, sometimes you don't even see it if the MRI is too slow. And if the MRI is too fast, then you get a jagged image for things like prostate or lung. In the brain, nothing is moving very much. The only problem with the brain is that eventually when you bring the patient to treatment, how do you make sure that their head is in the same position as the MRI scan? You need some kind of image guidance. Is that what you're planning, or do you then do a cone beam CT just before treatment and then rotate the couch, pitch the couch so it's exactly the same angle as the MRI scan?
So for this, I'll be actually looking through the repository for these image pairs. So I will have to, unfortunately, work with what they have provided. So that means that I'll be looking for specifically situations where they have, placed the head down with a lock that has been used for both the CT and the MRI procedure, and alignment generally between the CT and the MRI is usually done through registration. So I wouldn't know for sure how I could personally impact the actual method of taking the CT and MRI. I'm simply looking at the best quality pairs that I can find, essentially.
So at this stage, you're just looking at patients who've already had planning CTs
Yes.
and then trying to see if you can just implement the same Hounsfield units on the MRI scan. Is that the plan? Is it?
Yes, yes, yes.
Okay, so then the next step is probably the more challenging one, because the position of the head won't be the same for the MRI scan as to when the patient actually comes for treatment, and how to line that up. But I suppose that's the next person will be solving that problem.
Yes, yes. I think that's definitely something I would like to consider, probably at a later stage, perhaps in a more, I guess, clinically inclined, focused, I guess. And yeah, that definitely would be one of the things I'd be looking at for sure. Thanks, Gil. Thanks, Suki, sorry.
Rashid, have a question?
Yes, thanks, Arlyn. That was a very nice presentation. One thing about the challenges when you mentioned the registration and the uncertainties in registration, we can't put a number on it, can we?
Oh, sorry.
We can't put a number on it, can we? Like how much the uncertainty? Yep.
Yeah, unfortunately not.
And you mentioned something about the rigid registration being used only. Is that right?
Yes.
Okay, can you please explain a little bit more about that?
Okay, so essentially, the mutual information loss function that has been introduced by Kasemafar is a function which implicitly tries to minimize the differences between the synthetic CT and the actual MRI that's being used to generate it, as it works to through the cycle of improving upon its construction. And because it uses, I believe, what is called a joint entropy histogram, it is able to essentially, from a known variable that is the plan CT, it is able to minimize the difference in another variable, and I assume these are the variables within the MRI information dataset, such that this alignment is not necessary, because they don't need to essentially be registered, like deformedly registered, because the mutual function is doing that deformation registration as it's performing anyway. So that's kind of how I understood that difference of not using the I guess the rigid registration only as the beginning to register the MRI to the appropriate CT, but then letting the model do the remaining deformation ones itself while it's there.
I see. And then which were they using velocity for their registrations?
Yes, yes.
Okay, right. And the other question I have, you mentioned treatment planning.
Yes.
So are you going to use the existing treatment plan for that patient, for each patient, and like recalculate on the MRI, like the CT that is created from the MRI?
Yes.
Okay. So, but then your contours may change a little bit on, well, hopefully not. Okay, we'll see.
Yeah. So
okay.
I'm hoping that the contouring will be similar enough.
Similar.
And from what I read in literature, the contours are especially similar. It's generally some other artifacting that might be a bit different. Yeah.
Sure. Thank you.
Thank you very much.
Okay, Nathaniel.
Thanks, Alan. Great presentation. I was just wondering, I'm not sure if you mentioned it, but where are you getting this data from? Are you looking to get it here at Charles Gardner, or are you first going to look at some open source data sets?
I believe, and Jake, that this is more with Jake here. Correct me if I'm wrong, but I believe there's a local repository at Sir Charles Gardner Hospital which we've gotten ethical approval for, and to look through this repository and find data that would be pertinent to this this project. Am I wrong with that, Jake?
So we will be retrospectively acquiring the data from Charlie's patients. That's right.
I think you're talking about the FIG data set, is it? Or the
no,
petaglioma? No, not that one. There's a separate
won't
one.
be the FIG data set. Yeah, although actually that's a potentially a good point. We might actually be able to use some of that data, but that's perhaps a discussion for another day.
Okay.
So I'd be pretty cautious about the time management portion of the project then, because you're aiming to get like potentially around 150 patients from what it looked like, and that might take quite a lot of time. So in terms of your plan, I'll just plan to dedicate like most of your time to data acquisition and pre-processing.
Okay.
You also mentioned that you wanted to, a lot of the papers you looked at didn't really account for maybe different MRI vendors and different acquisitions, but maybe Sue can correct me here, but I'd imagine these patients really all get, acquired on the same image with the same sort of standardized sequence. So I'm not sure if that's something that can be evaluated in this project. I'm not sure if Suki might know if what the imaging is like, but yes, I was wondering what your thoughts might be on that.
Sorry, say again. I didn't catch that.
I was just wondering, Suki, are these patients acquired? They're probably acquired with a standardized imaging protocol on the same scanner, at least for brain metastases. Would that be correct?
Definitely. It's called a stealth MRI scan. So it's T1 plus contrast, and it's 1 millimeter slices. So in fact, what happens is they process the MRI scan so that if you do an MRI scan of a phantom that's, let's say, a cube, it'll actually be a little bit rounded at the ends. So there's a displacement. The further away you are from the center, the more displaced that MRI data set is. And so they post-process it to put it in the right place. But they have to know that it's a planning MRI scan, because otherwise for them to diagnostic MRI scan, they don't need to post-process. So you can't just take any MRI scan from the outside. And I suppose that to some extent, you also have to check what post-processing they've done to correct for that error, you see. The displacement is quite a lot. It's 2 or 3 millimeters at the edges, about 5 centimeters away, it's about 2 millimeters away.
So if that's the case, I think your suggestion of looking into more open access ones as a supplement might be an option for me then to really look into the multi-centering issues. Thank you for that. I'll need to look into that for sure. I had a feeling that there wouldn't be too much variation in the MRI devices that are being used. But that was, I guess, my hope that there would be.
Yeah, I think it'd be really great, and it might save you some time as well, is to potentially, develop a model on a good open source data set if it's available, and then validate it internally for Charlie's. So maybe that might be something you might want to consider as well in the scope of your project. But thanks for answering those questions.
And thank you for the questions.
Nathaniel. We'll go one more, Bryony, and then we'll have to call it because we're a bit over time. But
Sure,
Bryony,
I know. Yes, you've had a lot of questions fired at you.
Yep,
Very
no
nice
problem.
presentation. I'm very impressed with the progress of your knowledge on this topic in such a short amount of time. I had a brief comment. So in slide 7, you said with respect to deformable registration,
Yes.
your moving image will be the MRI and your fixed image is the planning CT. And I just wanted to ask you, with respect to the MR-only workflow, can you foresee any issues with that arrangement?
I think I may have put it the wrong way, actually. I guess my thinking was that ultimately the unperturbed image that we want to get to is the planning CT, and how the MRI is deformed shouldn't matter because it is being done in a way, being done so through the GAN network. And anyway, like the general the conditional GAN, for example. So not at this moment, I don't see any problems, but if I'm missing something, please, I'm welcome to be enlightened.
Yes. So I had this exact consideration. I was doing a similar project, and I guess I ran into the same problem, and I actually experimented both ways. But basically, with the MR-only workflow, you're not going to have a planning CT to deform to. So potentially the image spacing, voxel spacing, which you can resample, it isn't ideal to basically change your input data to something that you won't actually be able to replicate in real life or in the real workflow. So from that point of view, it would be better to have your planning CT as the moving image. It doesn't tend to perturb the image quality as much as you might think. Typically, the spacing isn't that great. The difference between the spacing of the two images isn't that much, so you're not going to get as much resampling errors.
Yeah.
So that's kind of one design choice. And I know we're a bit over time, but also I think it's important to decide on potentially an architecture and an approach to handle the misregistration early on, because that will also influence what sort of input data and ground truth data you're going to be working with. So are you only going to stick to the rigid workflow, or will you apply some deformable registration to then potentially use that as an additional way to mitigate anatomical differences, and also considering cycle GAN, which doesn't necessarily need paired data, versus this mutual information approach. They're all many design choices, and I'm keen to have a discussion with you moving forward. But in any case, very good work so far, and I really enjoyed that presentation.
Thank you very much.
Thanks.
Hey, thanks everyone for the questions, and thanks Arlyn for the really good proposal presentation there. I'm going to stop the recording now.